crossed out gastroenteritis from our old list, but we kept hepatic disease, ulcerative colitis, acute mesenteric ischemia, and appendicitis. And there are the symptoms again and the other symptoms that she doesn't have. So we ordered a little more tests this time to make sure that we are not going to do another misdiagnosis. We had the complete blood cell count, general chemistry panel, prothrombin time, which indicates the time it takes for the blood to clot, an activated partial thrombosis time, an angiography, which is performed by the radiologist, and a bowel CT and a barium enema, also performed by the radiologist. So the CBC showed that there was elevated white blood cell count. The stool test indicated high amounts of blood in the stool, and there were elevated amylase levels as determined from the general chemistry panel. Her PT was 14 seconds, and the reference times are up there, so this was slightly higher. And her APTT was 22 seconds, also slightly higher. So this is her scan from the angiography. From the top arrow, that is a healthy part of the artery, and on the bottom arrow you can see the narrowing of the artery, so that is the problematic area. And here's the barium enema. They add a barium contrast to the blood vessels to highlight all the problematic vessels. And you can see the narrowing there as well, and it's a little bit more defined. And this is a small bowel CT. The arrows point at the bowel walls, which are thickening, and this is also known as bowel wall edema. So from the radiology scans, I just summarized those. So they show a narrowing of the superior mesenteric artery and the bowel wall edema. So we determined that she could have one of two diseases, either acute mesenteric ischemia or ulcerative colitis. And to narrow down the actual diagnosis, we also had to perform a colonoscopy because we wanted to make sure that it was just one disease. So if the colonoscopy results determined ulcerative colitis, then we'd know for sure that it is that, or the same case for acute mesenteric ischemia. So the colonoscopy is where a general surgeon endoscopically inserts a probe, and a probe attached with a camera up the rectum into the bowel, and it can detect inflammation, swelling, or thickening of tissue and ulcers. And so she went under general anesthesia because she's an Alzheimer's patient and we didn't want any disruptions during the process. So the colonoscopy confirmed no ulcers and no inflammation. So given the above observations, we determined that it might be acute mesenteric ischemia and not ulcerative colitis. So acute mesenteric ischemia is caused by lack of blood flow to the bowel caused by the superior mesenteric artery. And the mortality rate is 70% because the disease is too hard to diagnose, and there's a large chance of misdiagnosis. So she must be taken for an exploratory laparotomy because we need to see if there's any necrotic tissue. And depending on those results, we will take her up for a bowel resection. Now, she cannot give consent for the exploratory laparotomy, and we had to get it from the next of kin because of her disease, and she can't give any medical consent. So this is a model that I created of what acute mesenteric ischemia looks like in the body. The blue circles are where the arteries are healthy and they supply good blood. And over in the green boxes, those are necrotic tissue, which is dead tissue that can spread around. The yellow circle is where the blockage is in the superior mesenteric artery, and the red circle is where there's the damaged artery. So we wanted to know exactly which organs were affected by the disease. We wanted to see if there was any necrotic tissue, and this procedure would confirm that this was indeed acute mesenteric ischemia and we're not performing another misdiagnosis. So this picture is a little graphic, I'm sorry about that, but the general surgeon will open up the abdomen and examines the abdominal organs and then sees any damage done to the organs. So she needs this procedure because CT scans may not be as accurate, and she went under general anesthesia for this procedure as well. And the surgery did lead to the discovery of necrotic bowel tissue, and so a bowel resection will be performed. Now, in the bowel resection, the general surgeon opens up the abdomen and they remove any necrotic tissue. This procedure could be done endoscopically, but since she already had an incision open, we decided to continue from there. And I was assisting on the surgery. The cardiovascular surgeon removed the blockage in the superior mesenteric artery, and then an arterial reconstruction was performed. And since only parts of the bowel were removed from the necrotic tissue, an anastomosis was performed to connect the remaining parts of the bowel together. So this is post-surgery. She was prescribed with papaverine and heparin to help with the healing process, and those were IV medications or intravenous medications. And since she went under 2 open surgeries, she must go under a 6-week recovery process, and she must stay in the hospital for a week for observation purposes. We don't want there to be any infection. So she also must stay under constant observation at her living community by a bedside nurse so that she can also monitor her behavior, any abdominal pain, and any infection. And unless she has any problems, she's coming for a follow-up visit in 6 weeks. And there is an alternative method that we could not perform because of the damage done to Elizabeth's arteries, but it's something we would have liked to do. Since she went under an arterial reconstruction, we thought there was a less invasive way to do it as well. We could use a stent graft, which would be inserted through the groin up to the superior mesenteric artery, and it would provide stability for the artery. This is usually used for aortic aneurysms, but if a smaller graft was created, it would be able to sustain the pressures from the superior mesenteric artery. And this would be minimally invasive compared to Elizabeth's procedures. So 6 weeks later, she comes in, and she says that she's doing better, and so does her nurse. So her incision sites are healing slowly, but that could be due to her old age, and there's no infection. So she does not feel any abdominal pain other than at her incision sites, which is completely normal. And she will be cared for by the bedside nurse for a few more weeks, and then she can remain to her old life. And she must come into the hospital immediately if there are any other further problems. These are my references. Thank you so much for listening.
So do the judges have any questions? We're good?
I thought the model you made was very cool.
Thank you.
The question I had is, I'm not sure if I missed it, the physical exam before the tests were ordered. Could you tell me about that, please?
So what the primary care physician did was that he applied pressure to the abdomen to see how she would react, and she did scream a lot, and she was feeling a lot of pain, and that's how she came up with the symptoms, and there was indication of distension there, so that's how the physical tests were performed.
And how about the surgeon doing the physical exam before the surgery?
And that also, the surgeon assisted when they were doing the second diagnosis. So again, he found the same symptoms and a little more pain from the patient. So from that, he determined that he would take out the gastroenteritis, and he would try to find an alternative method to saving her life.
So was the pain on exam, it was everywhere, or was it?
It was more lower, in the lower part of the abdomen, and it was very sharp and severe, so she felt it very acutely, as it says in the disease name itself. So.
Can you explain to me why the alternative method was not performed?
Well, there was way too much damage from the surgeries anyway, and since we already opened up her abdomen once, we felt that it would not make sense to go in again with the laparoscopic method when the abdomen's already open. So we performed multiple surgeries at once.
Okay.
Sorry, I have one more question.
Of course.
For the tests that you ordered, you mentioned a CT scan, a colonoscopy, an angiogram, and I think one more test. Did you plan on doing all of those simultaneously, or did you prioritize them?
Well, we prioritized them, so the angiography and the CT were top priority, and then the barium enema was just a second confirmation to the angiography.
Thank you.
Thank you.